Okay, I'd like to start by acknowledging the traditional owners on the land in which Karl and I are based at the moment, the Wadi Wadi people, and we pay our respects to their elders past, present and emerging, and also we acknowledge any Aboriginal and Torres Strait Islander health professionals who might be in the audiences today. The presentation that we're going to run through in the next hour is going to start with my story, because in the first 2-3 weeks, Karl was unconscious and doesn't remember much about the time at all. Our key messages from the presentation are that communication was really essential and important for both of us, particularly for me in the first 2 weeks when I thought that Karl might die. And the professionals in the hospital, the professionals who I communicated with by distance, made a real difference to my anxiety as a carer and a family member. And for Karl as well, during the time that he was in hospital in a Spanish-speaking country, communication is really important. So we have some messages for you there. Kindness came through from all the professionals that we interacted with in Uruguay, and we wanted to stress again and again through the presentation how important it is to be kind to people, to be human in the interactions that you have with individuals and with their families, because it makes a big difference. A lot of the talk is about the goals and measurements that we took. I spent a lot of time recording the repetitions that Karl was doing and using that to give him feedback about how he was changing over the 3 months that he was in hospital and in quarantine in a single room. You'll get some ideas for setting up practice in a single room when somebody's in isolation or in intensive care and linked to oxygen or various contraptions. So it's not essential to take people down to the gym for people to do worthwhile practice. And Karl will tell you about where he's at with his recovery now, 6 months on, and the sort of goals that he's working on at the moment. We started our trip in March on a 3-week tour down to the Antarctic Peninsula with 2 girlfriends. We started at the lower part of South America in a town called Ushuaia. And that was right in the middle of the beginning of the COVID era. We were traveling for 3 weeks down to the Antarctic Peninsula, then up to South Georgia, back to the Falklands, and then returning to Ushuaia. That was the plan. You can see in the top left of the picture that we did manage to make it to the Antarctic Peninsula. So we had about 6 days of traveling, having lectures, having lovely meals. And then on the 22nd of March, the first 2 passengers were recorded with a temperature. We had been having our temperature taken every day in the evening before we went to a lecture and before dinner. And once the temperatures were recorded, those passengers were isolated in rooms, and the rest of the passengers were also isolated in their cabins. So we had our meals in our cabins, and the shared meals and shared lectures stopped. At the same time, the boat shifted direction, and the cruise company, Aurora Expeditions, decided that they would head back to the mainland because the borders were closing. I should mention too that when we left, we really didn't think we were going to be at risk of COVID. We felt that we know differently now, but we were going to be on a cruise ship. We would be away from the majority of people, and we would be quite safe once we were away from the mainland. We now know that we were really on a traveling petri dish, and the infection and the virus spread very quickly once one person had acquired it. So we headed back to, it was initially going to be the Falkland Islands. We were going to dock, but they wouldn't let us come to the land, and they wouldn't allow us to the hospital there either. So the boat then steamed straight on north to Montevideo and the harbour of Uruguay. On the 25th, while we were sailing north, Karl developed a temperature, and the temperature continued to rise over the next few days. He in addition to a temperature, he had vomiting and nausea and diarrhea. He was generally very unwell, and of course that characteristic dry cough that you've probably heard about was particularly persistent and meant that he couldn't sleep lying down for the last 2 nights on the ship. I was having regular contact with the ship's doctor, as was Karl. He was still awake, still alert, but very unwell. So they negotiated with the Uruguayan Ministry of Health to get Karl off the ship, and on the 31st, a Navy boat was arranged to come and to transfer Karl to the hospital. And you can see on the right there, he was kitted out in PPE gear, very hot, very difficult for him to breathe, to hear and to see, in preparation for transfer to the ship. He also had an oxygen concentrator, so was requiring that for breathing, as well as an IV drip and IV antibiotics. The video I'm just about to show you is the Navy ship that came to meet Karl, and the seas were very rough, and he had to jump across. If you watched the SBS Dateline show last night on television, you'll see how choppy it was. So that was my video taken from my balcony. I could see how scary it was. I had to stay on the ship. I wasn't allowed to go with Karl. And that was the last that I saw of him for 3 weeks. At that point, I didn't know whether he was going to live or not. But I spoke to him about 4 hours later, once he'd arrived at the hospital. He'd been assessed. He was, he was doing okay. He wasn't any worse. I went to bed, and then an hour later, I got a call from the hospital to say that he'd been admitted to ICU, and at that point was intubated and unconscious. The next day, I received communication from the medical director, who told me that Karl was very seriously ill. And for anybody who works in rehabilitation or in health, that's code for we don't know if he's going to survive the next day. I had support from the the Australian Embassy every day, from the insurance company, our travel insurance company every day, and from my 2 girlfriends who were on the ship. One was a nurse, one's a physiotherapist. We've written a blog, or I wrote a blog from my diary entries during the trip. So for anybody who's interested in reading a bit more about this, you can take a screenshot of that or contact us and have a look at the diary entries and photographs, some of which are in this presentation. I mentioned communication was really important, and the medical director called me a couple of times in those first 2 difficult days. And after that, I had to call the hospital myself every morning at a specified time. They would try to find somebody in intensive care who spoke English. Sometimes they did, sometimes they didn't. So not every day would I get an update from the staff in ICU. I couldn't see Karl. He was still unconscious until the 7th of April, so it took about a week before he was responding to commands and woke up. So those were very difficult days for me, not knowing what was happening, sometimes not being able to get communication, and that really increased my anxiety significantly when I couldn't get an update from the staff. On the 7th of April, which happened to be my birthday, the ICU doctor sent me a photograph by email of Karl, who was now awake and responding to commands. And that was one of the photographs that he sent me. It made a big difference to my day and my life. I could see the room that he was in. I could see that he was now awake. I knew that he probably couldn't hear very well because he didn't have his hearing aids in, but I could see that he was alive and alert. Karl says not very alert. He was actually hallucinating quite a lot. Then a few days later, I moved to the hospital. I was transferred to a ward in an isolation room in just very close to the ICU unit. And one of the nurses helped Karl to get his phone charged and also to put FaceTime onto it so that we could communicate. And what you see there is a screenshot of our very first video chat We had some phone chats on his mobile phone initially, but it was very hard for me to hear him because of the oxygen, and for him to hear me without his hearing aids in. So the video technology made a huge difference. Now, with isolation and quarantine and hygiene, getting the mobile phone out and in use took quite a bit of convincing of the staff. There was no telephone in Karl's room for me to use, so he had to use his mobile phone. And as I said, it made a big difference. So at that point, I might stop and see if there are any questions or comments from anybody in the audience before I pass over to Karl to give you his point of view once he was awake and alert. If there aren't any questions, then I'll just keep going, but I'll give you a chance to...
So just wondering, hi, Annie, being here. Thank you so much. I was just wondering, how bad was the pandemic in Uruguay back in those days at late March?
So the question is how bad was the pandemic in Uruguay? They had it very well contained. When Karl went to the hospital, I was assured by the medical director that they'd had about 20 cases of people with COVID in the hospital, and they'd all been discharged home. I was very reassured by that, but I realize now that they probably didn't have anybody as severe as Karl at that point, and that was in fact the case. By the time we left 3 months later, they I think had 10 or 11 deaths in Uruguay, and it's a population of about 3 million, so they were managing it very well. They didn't have the same lockdowns that we had in Australia though, and they probably didn't need it.
Thank you. No other questions, I think. Annie, thanks.
No other questions?
No other questions, thanks.
Okay.
Okay, so it's my turn. I think one of the things that's sort of fascinating, having been a recipient of the virus, it comes with many gifts. But one of the things that we've learned over the last 6 months is that really the evidence about it is just evolving, and the understanding is still, while it's growing, it's still not clear. But the consequences are that it seems to affect multiple organs, and there are various theories about why that might be, and whether it's your immune system that actually goes berserk in response to the virus or not is one of the theories that's being seriously considered now. But what does happen is that there seems to be significant coagulation changes within the bloodstream, and D-dimers are strongly correlated. Changes in D-dimers, increases in D-dimers are strongly correlated with the COVID-19 infection. It can affect multiple organs. For me, it was primarily affecting my lungs and my heart. I had nearly 3 months of fairly significant cardiac arrhythmias, which have now settled primarily. It's very rarely that I get them now. But I also had a couple of days of kidney failure in ICU, and Annie will have to attest to whether my brain's affected or not, and I don't seem to have any skin changes. But for other people, and particularly young people, while they may not be admitted to an ICU unit, there is persistent physical, cognitive and psychological impairments, including chronic fatigue, which seem to persist for many months. So that's a really awful outcome of the disease as well. And the other thing that I was really apparent, and you can see from this photograph, I lost, on estimate, at least 10, maybe more kilos, and I didn't have all that many to lose. So about 15 or 20% of my body weight was lost in that very short space of time. And that had significant implications for my practice. To give you some idea of the effort of breathing, this is a video that Annie took when I first started sharing a room with her in the same hospital. Here I am on a reservoir mask with 6 to 8 litres of oxygen. And this was pretty much my characteristic breathing for that first sort of month period. after I was discharged from ICU. So my lungs are severely challenged and dependent upon supplemental oxygen to be able to continue to live. Here are comparative x-rays. The one on the left-hand side of the screen is my lungs at 17th of April. And you can see there's very patchy changes throughout the lung fields in comparison to the x-ray on the right, which is quite clear, and you can see the base of the lungs and the clarity around the upper lobes and so on that aren't present in my lungs. My lungs are severely affected throughout all of the lung fields. One of the things that was very apparent to me immediately upon waking up out of my period of hallucinations, which probably lasted 2 or 3 days, was how profoundly weak I was. So I couldn't move in bed, I couldn't lift my legs, I couldn't roll over in bed, I couldn't lift my arms off the bed. And so I sort of went straight into physio mode, in a sense of saying, what do I need to do about this? This is a difficult situation, but I need to start practicing, and what can I practice and what can I do? And one of the strategies that was apparent to me was just how weak my legs were. And so fortunately in the room, in the ICU room where I was situated, which was an isolated room on my own, is that they had a block of rubber that I could ask them to put at the end of the bed that I could push on. So even though my legs were profoundly weak, and certainly I wouldn't have been able to have my leg as this flexed at the beginning, I was able to then use that to push against, so that it gave me a chance to be able to work on my leg strength persistently throughout the whole day. And so what I used was the desaturation alarm to guide my practice. And so when the desaturation alarm went off, the staff would come running to the window, so I knew that wasn't a good thing to happen. And so I then started to count the number of times I could push on the block before the alarm went off. And so I could then start to learn to modulate my effort to not make so much of an oxygen demand, but still keep practicing. I then, once my leg muscles started to turn on more reliably, I then went on to sustaining contraction and how long could I keep contraction going for before I started to desaturate. And one night when I couldn't sleep, which was fairly regular really, sleep post-ICU is difficult, was 900 repetitions, and the alarm only went off twice. And these sort of measures I was able to share with Annie to tell her how I was going. And so this is another way for me to start to keep a record of how my practice was going. As my legs got stronger, I was able to do a kind of assisted transfer into a chair next to my bed, and then start to practice pushing on my legs, getting my trunk to bend forwards and back, to start to use my hip flexors and hip extensors and knee extensors to push into the floor, to be able to learn how to use that leg strength to control my trunk. So here's a contraption that they used for us. It was a kind of metal frame that I sat in, and they tied me in with a sheet. And the idea of this exercise was to teach me how to sit. But all I can say really is that this didn't teach me how to sit. It merely taught me just how profoundly painful this was, because my legs weren't strong enough to hold me up. And so I spent some time talking with the physios about how this wasn't a good strategy to practice sitting, but what I needed to do is practice making my legs stronger so I would be able to sit. And this took some time to get that message across. As far as my arm function is concerned, I really did use my functional needs while I was in ICU, because the exercises that the physios were giving me, and they were seeing me twice a day, so that was fortunate in relationship to my lungs. But unfortunately, the arm exercises I was doing didn't in any way relate to the tasks that I wanted to do, like eat, and be able to get my hand to my mouth, to be able to hold my arms up long enough to get my hearing aids into my ears. And so I just developed my own training strategies based around those skills when I was lying in bed. So I had specific practice exercises that I would do. And then next time I ate or next time I tried to put my hearing aids in, I'd see whether in fact those tasks had changed and become easier.
And I could actually see that on the FaceTime videos when we talked 2 or 3 times a day. And I could comment on the things that he was able to do that he couldn't do previously. Karl also had some swallowing problems. I know there might be some speech pathologists in the audience, and he picked that up himself. He noticed that when he was drinking his coffee, a lot of it, he coughed and spluttered. So I talked to the dietitian about modifying his food. There was no speech pathologist in the hospital that could have seen him, nor was there an occupational therapist in the hospital that could have seen Karl.
So I suppose my neurology knowledge was helpful in terms of working on strategies that I could start to implement myself. But so it then became that I was drinking out via a straw, taking great care over the amount of drink that I was putting into my mouth and so on to control that. I must say the physios were diligent in coming to see me every day. But one of the things that was hard in those initial days was that the exercises that they were doing with me were very much around mobilising limbs, which in some ways was a good thing. But as my muscles got stronger quite quickly, it was no longer relevant for me to actually have my arms and legs moved around. It was much more relevant for me to actually practice the elements of skills that I needed to do to be able to stand up, and those skills that I really wanted to acquire. So they spent a lot of time working on my lungs, which was really, I was very, very happy for. But in fact, my lungs were not productive of sputum at all. It was very much lung damage resulting from the virus itself. So we went from waking up and responding on the 7th to my first FaceTime chat with Annie, and then I was discharged to a room to share with Annie on the 24th, which was a celebration day. What I would say now is that it actually was very helpful for me to begin to have an in-house coach, if you like, because Annie was meticulous in keeping a record of my practice, how many times I was able to do things, how much oxygen I needed, how much desaturation I had, what my heart rate went up to, so that we could actually keep a record of how I was changing over time. And it meant that we would time how long I could sit for, and that may have been 30 seconds initially, how long I could stand for, the number of times I could stand for, and particularly standing up and sitting down, which really required a much greater oxygen demand of my legs, was profoundly difficult and took me a long time to learn how to do repetitions of practice of sitting to standing. On the advice of physios here in Australia, Meredith King particularly, and also Anne Holland in Melbourne, there was a number of very, very helpful tips I got, because I was really approaching this from a neurology point of view and a muscle strength point of view. And they were able to give me quite much more clear guidelines about lung repair and the needs for my lungs to adjust, and how I could change the way I was practicing. And some of those exercises revolved around doing air exercises with my arms, just to provide an increased oxygen demand for my cardiovascular system. In the room that we're in, we had about a 4-metre length of the room, which we measured with a tape measure, and we used that as a walking distance measure over time. So my abilities to walk then went from 70 metres initially, which is lots of turning around in a small space, to 93 metres, and then to 120 metres after that. So it's important to have measures to show how you're changing, because it's really hard yakka. The other thing that was very helpful for me was this breathing app on the phone, which is free, which is called Cardiac Coherence, which gives you timed inspiration and expiration. And one of the things that was very, very distressing for me at this time was when I started to desaturate and significantly desaturate, particularly going to the toilet on the commode chair, having to hold your breath and try to push, then meant that I desaturated rapidly, and I would drop into the low 80s quite quickly. And it was really quite scary. It caused almost an emotional response in me, and I would need to lie down and spend some time after that recovering. And cardiac coherence really gave me some strategies on how I could just practice to relax and concentrate on breathing without as much effort, and try to decrease my own distress. When I was COVID negative, Annie was COVID negative before me, we were then able to go outside and actually in the hallway to practice with a mobile oxygen cylinder and walk up and down the hall. And we would do a number of times a day, and I was able to get up to about 4 kilometres a day just walking up and down the hall. And as I was saying, this advice I had from Australian therapists was extremely helpful to help guide the way I was practicing, which actually made a big difference to me. In terms of the goals, we're looking at simple goals, but important goals. Standing beside the bed, how long I could do it for, how long could I sit out of bed, then walking to the window, then the toilet, using a bedside commode, and then progressing to be able to walk to the bathroom toilet myself. And really the joys of having a shower, which I cannot tell you is how wonderful you can actually go to a shower, even if you've still got an oxygen mask on, to have a shower on your own is just something that's quite wonderful. And the other thing I needed to work on was to try to increase my body weight without a large appetite, I must say, from day to day. Here's an example of me practicing my sitting practice early on. You can see on my finger there's an oximeter, which I used, became my companion for those 2 months, really giving me information about how I was desaturating in terms of the exercise and what my heart rate was doing. But this was about the limit of my capacities at that time. So here I'm basically flexing and extending my hips 3 times, and it takes me 42 seconds. So we were able to use measures like these to show from one day to the next how my performance was changing, and then 1 week to the next how different those things were. So simple measures are really very, very powerful to keep you practicing. Here's a standing example. And here you'll see Annie in the background.
I can tell you how long it is on here.
Counting the seconds that I'm taking to get to a minute.
That's 15 seconds.
That's amazing.
20 seconds.
Once again, it's really important because you're pushing towards your limits.
25 seconds.
To get feedback about how close you are.
30.
Trying to get to. And for me, standing for 60 seconds.
35 seconds.
It's really hard work. My shoulders
40.
lifting up and down, accessory muscles are trying to help in terms of my breathing.
45 seconds.
And I will be on at least 6 litres of oxygen at this.
50. 55 seconds. 1 minute.
This is my first walk to across the room. Once again, very tentative, but very exciting to be able to move across a room without assistance from somebody else. But in many ways, this reflected the practice that I had been doing with Annie over the sort of week and a half before this, really to try to get my legs stronger, to work on the sitting balance, to work on sitting to standing, to get to the stage where my legs were strong enough.
I'll just make a mention now about equipment as well. There you can see Karl walking to the toilet, which was a few days later once he was able to walk the distance to the chair. But I spent quite a lot of time negotiating to get a comfortable chair in the room for Karl, because everything was plastic and washable, and because he had no muscle bulk underneath his legs, sitting on a plastic chair meant that he couldn't stay there for more than 5 minutes at the most. Even with a pillow on it, it was still uncomfortable. So we negotiated to get a chair brought in, and that took 3 weeks, which if you think about the rehab timescale is a long, long time. Getting a commode chair beside the bed took 2 weeks, and the insurance company was going to try and get one brought in on a rented basis. The hospital would not allow any equipment to be brought in from outside. So all of these additional activities, getting equipment, didn't happen easily.
So maybe we can sort of stop at that stage and see if there's any further questions from the audience.
Karl and Annie, it's Sue. Thank you for articulating so clearly the physical demands of that time. It's a risk of re-traumatising you. I wonder if there's any insight over the first few weeks about pinch points as far as motivation or willingness to keep working. You were obviously highly motivated as an individual. You were educated about what you needed to do. For our patients, any ideas about when the critical points might be in helping them over those motivational humps?
I mean, I guess I could talk as a family member about what, did you hear the question?
Not particularly.
So what sort of helped keep you going and kept you motivated? And I think the measurements and the goals, we kind of set them ourselves, because that wasn't really happening as part of the process in the hospital that Karl was in. He was having treatment for his lungs, and we were seeing a doctor every day, but the goal setting was something that we did ourselves. The goals, I think the main goal for the hospital was getting us on a plane and getting Karl well enough to get on a plane. But we needed day-to-day, week-to-week goals that could show Karl how much he was changing. Part of my job as a coach was making sure that Karl did do the practice each day, because he needed to sleep a lot. And so I would say, you've only done this much today, you need to do a bit more, and we'd kind of pace that through the day.
Yeah, I think it is an interesting thing to reflect on, because I think I came to this challenge with a lot of background information, and I knew how hard stroke survivors have to work to be able to recover their capacities to do the things they want to do. But I've also practiced a lot of those strategies working with people that don't have any knowledge of the importance of practice, and I suppose utilising strategies like measurement, like practicing tasks which are of value and benefit to them, and then linking their practice to how they're going to get better at that skill. I think part of our responsibilities as health professionals is to find ways to excite somebody to practice. Quite often people you'll hear is saying this person isn't motivated. They don't want to do their practice. The problem with that is that if you think about a hospital, it's a seriously strange place which isn't motivating. There is nothing about a hospital which is motivating other than wanting to get out of the place. So one of the challenges that we have as clinicians is how do we excite somebody to know what they need to practice and help them be able to practice that, and provide them with strategies that they can do on their own, so they have some agency to improve their skills to be able to get out, so they can see there's some way of getting out. And part of that is probably educating somebody and spending time with them, listening to what they have to say, finding the things they can do rather than the things that they can't do, which is what we do as clinicians. We do tests all the time, finding out the stuff that they can't do. They already know that. They know what they can't do. We need to find stuff that they can do and then work from that. So it's a challenge. It's a big challenge. And I think Annie and I have both used our skills extensively in the last 6 months to learn how to practice at a personal level. But it still reinforces those things we've been saying for a long time about the need for goals, the need for measurement, the need for practice, those things are still consistent, but we may need to find just different ways for each individual to find a way that excites them to practice.
Thank you very much. Another question from the floor.
Hello, my name is Marta. I'm a social worker at the Understanding Hospital. Just a quick question to finish up. With the allied health team at the hospital in Uruguay, did they adapt some of your strategies that you took on to, for your recovery? The OT and the physios there in the hospital?
Right. I didn't quite hear that, so maybe if Sue or Steph could repeat it.
The question was around whether or not the allied health team at the hospital adapted some of the things that you had implemented. Is that right, Marta?
That's correct.
Yes.
Towards the finish, yes. I kind of developed quite specific relationships with different physiotherapists, because they were the ones that were seeing me daily, and some of them were more interested in the things that I had to say than the others that were just following a recipe. And those ones I just kept having conversations around the importance of leg strength and how to sit and the muscles that were important and why they were important, and how look at what's happened to my legs now that I've been practicing these things. And they showed significant interest in the approach that I was taking, because what eventually happened for me was that I let the therapists work on my lungs because they felt good when they worked on my lungs, which is me really sort of passively receiving some fairly vigorous chest manipulations and so on. But I refused to do their leg exercises. And I refused because they were stupid. They weren't sensible in relationship to the things that I wanted to do. And so it took me a long time to convince some of the therapists that this is why I was doing what I was doing. When they saw the degree to which I was changing, they then showed some interest in what I was doing. But otherwise, they would have just followed a recipe about the exercises that they just routinely do without necessarily thinking about what does this person need versus that person. And I think that's what we really need to be careful of when we're working as clinicians, is to find out what this particular person needs to do.
Okay, we might keep going just so we can make sure that you get back to work at the time you need to go back. We've already talked about measurements, so I won't spend a lot of time on this, but I was able to show Karl changes in his timed up and go test, from 12 seconds to taking less time, 8.5 seconds, down to less than 8 seconds over a period of a couple of weeks. And we're able to Google what was the normative data for that particular test for somebody of his age, and he was within that range. But of course, after he'd done that activity, he was quite stressed from a breathlessness point of view. Karl's mentioned the 2-minute walk test, which he was able to do shuttling backwards and forwards in the room. And you can see from the 11th of May through to the end of May, the week before we were flown back to Australia, that the distance he could cover was quite significantly improved and within normal limits by that time. He also was able to do 5 sit-to-stands slowly, but with oxygen. And over the period from the 24th of May to the 1st of June, could stand from a slightly lower chair and with less oxygen. So I'll let Karl talk now a bit about the lung recovery and pulmonary rehab.
So this is my CAT scan that was taken in Sydney after we returned from overseas. And the description here is that there's patchy increased interstitial opacity, which basically means there's interference with the capacity of the lung tissues to absorb oxygen, and distortion of that tissue with airway dilatation and bilateral patchy glass opacities. And these are things that are seen in people with chronic lung diseases as well. And the problem with many of these changes that they're seeing in these scans And here's a quote from a paper that's just published in the Lancet in July, where they're saying presumably the fibrotic pathological findings, that is those similar to in my lungs, are unlikely to regress in patients with severe COVID who survive. So that's me. So there are a couple of things going on. One is that there's a large safety margin, which I've been sort of pushing the limits of that safety margin for some time to actually compensate for the damage. But I still think that there's probably a capacity for the lungs to repair. And so my hope is that over the coming months and the ongoing demands of my lungs, that my lungs will continue to change and repair. But if it's only compensation, then that's still pretty good, because I've still got, as you can see in those changes over that time, my system is adapting to this new decrease in my capacity of my lungs. Over that time, there's a whole range of progression of things which I had no knowledge of, going from high flow oxygen masks, where it was difficult to breathe and talk and eat, and very, very noisy when we're on the phone to talk to one another, because there's this constant whooshing of air through your nostrils. Progressing to a reservoir mask, but that then means that you have this mask covering your face, and then eventually to nasal prongs, and then I could start to decrease the oxygen, amount of oxygen I was receiving as my lungs improved. So it went from 5 litres down to 2 litres, and that was important because we wouldn't be able to get on a commercial flight to return to Australia unless my oxygen demands were less than 2 litres, because the oxygen pressure in an aeroplane is much lower than what it is at sea level. So you do need to have supplemental oxygen. And I had supplemental oxygen all the way back on the flight from Montevideo to Sydney. And working towards that, I just started to trial periods without oxygen, starting on May the 10th, just turning the oxygen off and looking at my oxygen saturations. And when they started to drop below 90, I'd put the oxygen on again. And that changed relatively quickly over that period. It went from 10 minutes up to 8 hours by the 30th of May. But I wasn't able to do any exercise during that time. It meant that I would have to have oxygen on to go to the toilet. I would need oxygen to be able to exercise and so on. So there was this trade-off. So that'd be the times I'd be resting, reading, looking out the window, looking at the birds or whatever that was happening at the time, but I wouldn't actually be doing any exercise. Lots of medications, which I won't necessarily go through here, but this is something that was new for me. I'd never been on this number of medications before, and I needed to wean myself off some of them as fast as I could, and they included the antipsychotic medications and the sedative medications because they have a propensity for addiction, which I wanted to avoid.
Just so that you know, the one medication that Karl's still on is the anticoagulant. We knew at that point, fortunately, that stroke was a significant risk because of the changes in the blood. And so communications that I had here with friends in Australia and colleagues in Australia, everybody was saying, is he on an anticoagulant? Is he on an anticoagulant? Make sure he stays on it. And he's still on an anticoagulant and is likely to stay on it indefinitely. We didn't want to have a stroke happening on top of all of this.
Yeah, so our trip home is another story. We could talk about this for an hour, but basically the insurance company spent nearly a month trying to organise a way for us to get back to Australia. And eventually we had a medevac flight to Montreal, which is a long way, just heading north away from Australia, basically, and to catch a business class seat with a medical supervisor back to Sydney via Doha. So that was another journey along the way. On the return home to Australia, obviously we had 2 weeks in isolation, each in separate places, me in Liverpool Hospital and Annie in a hotel in Sydney. And my first goals were then around being able to walk to our local shops, then to extend that to be able to go bushwalking, to start to resume yoga and get back on my bike again. And all of those things have been achieved in the intervening months, which is very pleasing. The other thing that's been extremely helpful for me, and just to reinforce with those that are involved in telehealth, it's been, I can't emphasise enough how important it has been to have these conversations with Zoe Coleman at Liverpool Hospital, where we have conversations around measurement, around amount of practice, dosage of practice, and so on, and to review the goals that I've achieved and to think about further goals that I might want to achieve, but also using her expertise as a pulmonary specialist to be able to understand why I might be finding some things more difficult than I would normally or previously have expected, and to keep those things in mind. So I've found that extremely helpful and continue to have. Now they are monthly meetings, but I still look forward to those opportunities to talk about what's been happening, how things are changing, and where she thinks that I might need to go from here. And so those of you that are involved in telehealth, they are really very, very helpful, and I would reinforce the need for that sense of being still supported, even though you seem to be doing well. I've been doing sitting to standing practice with increasing amounts of weight, stair climbing at home with backpacks with weights in them, and we've had sort of focus around particular bushwalks that we want to do, and a weekly boot camp that I've started to go to with Annie, as well as some cycling. But here's an example of the stair climbing. You can probably hear me breathing away in the background there, but I'm now up to doing this 40 times, carrying 18 kilos, so that my capacities have changed and I've learned how to pace myself, and I can now push into strength as well as endurance, which is very pleasing.
Well done, Karl.
Here's one of our favourite bushwalks, and this was a hill that I had great fear of being able to get up, and being able to get up this hill, I didn't care how many times I had to stop, but just to be able to do that was a wonderful achievement for me. So just some reflections on rehab that perhaps for you to think about more generally is that when you come to work in a hospital, I think one of the things that's helpful for you to think about before you step through the door, because we become very familiar with hospitals and they become normal places to us as clinicians. But before you put your foot in the door, just think that I'm entering a seriously weird place. Hospitals are very, very strange places. They take away all your kind of capacities to do your own thing. They're profoundly disempowering. And one of the roles that we as Allied Health, I think, have a very, very strong role to play is giving people some power. So this is not only the person concerned in terms of their injury, or whatever that may be, but also the family members, and particularly with COVID, where family members and the person concerned are often separated, particularly in the acute phase, is how do you help people be able to communicate and start to feel a little bit normal, because it's completely abnormal. One of the ways that you can do that is to take measures of what somebody can do. If it's only lifting up their eyebrow once, that's something to celebrate, because they can do something. And then the next time you see them, you say, well, how many times can you do it? How many times have you done it since I saw you last? Show me how times you can lift your eyebrow up today. There has to be some conversation around what people can do to help them overcome the profound, they've had a catastrophe in their lives, and how can you help them out of that hole? When you're thinking about a task a person needs to do, then first of all, what is it they want to do? So maybe you need to talk to their family members about the things that they really like to do. And then our goal and our responsibility is then to think about, well, what essential muscles does this person need to be able to do that? How can I help them do that? What things can I set them up with in their room so they can begin to practice some of those things, so that next time I see them, I can ask them about their practice. How have they been going? What difficulties did you have? Can I change it in some way to make it easier? And so on. So you're starting to give them some agency in a place where they don't have agency really at all in terms of the processes and procedures that are done to you every day. So find something that somebody can do. Try to provide them with meaningful practice, even if it seems very simple. You have no idea how important it was for me to have that rubber blocks put at the end of the bed before the nursing staff left the room, so I would be able to practice. And they just got used to me kind of annoying them about, I want that thing, you know, find that thing for me. I didn't learn the Spanish word for it, but they sure as hell learnt that that's what I wanted. And so they would organise the environment so I would be able to do that. As I said, provide practice that offers some control. Keep a review of practice and measure so you can show that somebody's changing. And that's an important conversation to have, not only with the person, but also with their families, so they can begin to be part of that process. I might hand over to Annie now, and then we can perhaps...
I have time for a few questions before you head home. Head back to work. I've talked about the importance of having efforts to allow people, you know, Karl and myself, to do things on our own. That was really important. One thing that I found very strange was that the medications would come in 2 or 3 times a day, and they would give the medications to me right up until the last day that Karl left. They would give me the kidney dish with all the drugs in them, and then I would just say, you know, eventually I realized what was happening. They were just so used to giving the control to the carer. So that was just a little thing that you just don't, you're not aware that that's happening when you're working in hospitals. You also hear often, we didn't hear this so much in the Spanish hospital because everything was happening in Spanish pretty much. But people talk about my patients. Now, how do you think Karl feels being referred to as somebody's patient? It's a very odd habit that particularly doctors have, but you do hear some therapists talking in that way as well. Therapists asking you to do something for them. Karl was doing all of this work for himself, not for anybody else. So all of these disempowering habits of language that you have, think about what you say, and if you're not sure, record yourself and listen to your session. The other thing that I highlighted earlier was the importance of being kind, and that came through in all the interactions that we had with the staff in Uruguay.
Yeah, and that kindness I would have to reinforce was the one thing that really made me feel so welcome, and these people were taking an enormous risk. They could potentially get COVID from me in that environment. They were meticulous in terms of their PPE gear and all of the controls and stuff, but they were overwhelmingly kind. And that made such a difference in such a foreign environment. But for me, the future, lung recovery versus compensation, that's still a question. Do I have continuing cardiac issues? I don't know, but my next cardiac assessment is 12 months from now, so the cardiologist is quite happy with how things are going. I know that I'm facing ongoing training, and that will probably be a lifelong effort on my part, that there'll be some aspects of my day which is involved on training to improve my lung function. And I hope to continue the tele-rehab for some months yet, because that's been extremely helpful.
So, any questions from the audience? And I'll leave the slide up with our blog in case anybody wants to follow up on that.
Hi, Annie. It's Deb here. Can you hear me?
Yes.
Yeah, we have a couple of questions. One was from Free National and another one on another WhatsApp group from a therapist. And they asked how you managed the mental strain of the experience at the time and now.
So the question is, how did we manage the financial strain? Is that the question?
Well, actually, funny enough, that was the other question. The other question was, and this is from Robin Sims, you may not know, what were financial issues in relation to insurance and organising the return to Australia? That was the second question. The other one was about managing the mental strain of the whole experience, the mental, how you managed to cope with that.
Well, we had the insurance company, we had a very good insurance company, Covermore. I don't mind mentioning it because they were so good. And within 24 hours of Karl becoming unwell, we had the claim accepted because he had a new condition, a new medical condition that had not been present when he started the trip. So there was no question of that being covered. So that meant all of the medical costs were covered, which was, about $8,500 a day in ICU. And, it was similar costs once he moved out of ICU into the other hospital wards. So probably, several $100,000 in medical costs during the time that he was in Uruguay. Once we were in the hospital, there was no other expenses at all, really, because other than the telephone bills on our mobile phones, because the meals were covered by the hospital, and we didn't get out of the room until I had a couple of weeks before we left and flew home that I was allowed out of the room and into the Montevideo community. So yeah, we didn't spend any money from when we started on our trip in Uruguay until we actually got home in June. Then we had 2 weeks in quarantine, so I spent almost no money in that time.
That's the one advantage.
Yeah, and a business class flight home. Any other questions?
Any other questions from the audience here?
I like the mental strain.
Okay, okay, the other question was actually the psychological side of how you manage during and also how you manage now.
Yeah, I might talk about it for myself because I get that question quite a lot. How did I cope? And you just do. I think we both realized that we're pretty resilient. I think knowing a lot about health was helpful. I used lots of my connections, lots of my contacts to find information out. I used a psychologist. The cruise ship company organized for any of the passengers on the ship and staff to have tele-counselling with a counsellor who is based in New Zealand and had done a lot of counselling during the bushfires with people in Australia. So she was very helpful. I had daily counselling sessions for an hour with her, and she reinforced the CBT strategies I was using for not catastrophizing about things that were going on, keeping exercising. I was trying to do some meditation and mindfulness, but I just couldn't focus at all. And that cardiac coherence app that Karl started using, I had been using to help with my breathing and trying to help me get to sleep at nights. So, when I finished, came back to Australia, I was managing pretty well. The fact that we were together, we could get on and do things. We had some control. Now, the only thing that really makes me upset sometimes is watching some of the videos, occasionally talking about it. But I think the importance of sharing the story and making people aware of how dangerous COVID is outweighs the little bit of crying here and there that might happen. Karl hasn't really had any.
Yeah, it's interesting to me. I just kind of fell into physio mode when I woke up. I don't perceive any kind of PTSD type issues at all. It's very much around, and I was very fortunate in that my capacity to turn my muscles on changed relatively quickly. I think if I was still profoundly weak now, I think that would be different for me. I think if I wasn't able to do the things I want to do, then I think that would be psychologically very hard for me to adjust to. The other thing that is interesting is that period of coma. I vividly remember the hallucinations. I can almost describe them in great detail to you if you want to be bored. But the period of coma, the phone call that I had with Annie, that she says that we had together before I was admitted to ICU, I have no memory of, none at all. And I have no memory at all of that period of coma. There's nothing that it's just a period of my life that has disappeared. And so what Annie did during that time, which was very helpful for me afterwards, was wrote a diary to me. So it wasn't her diary, it was a writing of her feelings and the things that people were writing to us and so on, from around the world, which really just kind of knocked me over, really, was very much around what was happening for Annie at the time. And that was profoundly moving for me because I really had no insights into that, and I can't have because I was unconscious. But that's also been very important for me to know just how stressful it was for Annie, because I was just trying to stay alive, but I didn't know how, really.
And just one final thing that I'll mention, that the psychologist told me, which I was starting to do but needed to do it more, was not just talk to people on the phone back home, but to actually do what we're doing now and actually see people, see friends, see family, talk to them and see them, because that social contact is really important for helping you through difficult times.
Thanks. Are there any other questions? No, well, I'll wrap it up. And thank you very much, Annie and Karl. We're really, actually following your story the whole time has been really moving. And I feel really that everyone here will feel really lucky to have been able to talk with you today. So you really are very inspiring, and all your work has been. And then enduring this and your way of sharing it, through the news and here today, we really appreciate you. Thank you. Thanks, everyone.
Thanks for joining us.